Hello students, in today's session we'll be discussing cranial nerve examination. This is an important topic both for your practicals as well as theory. We have learnt about certain disorders which affect the cranial nerves individually in separate sessions, but in today's session we'll be discussing about examination of individual cranial nerves. So we know that we have the 12 pairs of cranial nerves that are there, the olfactory nerve, the optic nerve, the third is the oculomotor nerve, the trochlear and the trigeminal nerve, the sixth nerve is the abducens, the seventh is the facial, the eighth is the vestibulocochlear, ninth is the glossopharyngeal, 10th is vagus, 11th is spinal axillary and 12th is the hypoglossal nerve. So we have these 12 pairs of nerves and they arise from various parts of the brain. The olfactory and the optic nerve are direct communications, they don't come to the brainstem, whereas all the other cranial nerves are located in the brainstem. The third and fourth are located in the midbrain. The 5, 6, 7, 8 are located in the pons. The 9, 10, 11, 12 are located in the medulla. So various parts of the brainstem they are located. As we already know that there are only 4 cranial nerves which are located in the center. So you have the third cranial nerve, the fourth cranial nerve and the sixth cranial nerve which are located in the center of the brainstem as well as the 12th cranial nerve. All of the cranial nerves are located in this site. So this is the basic anatomy that we have to understand, and then we will discuss about the individual cranial nerves. Coming on to the first cranial nerve, that is the olfactory nerve. So it's the basic sense of smell that you're going to test there. So we are going to instruct the patient to close his eyes and we are going to get the substances to his nostril and ask him to smell. And the first thing, whether he is able to smell or not, that's the first question that we ask. If he is able to smell, then we can say, what is it? Is it a particular item that he knows? Or you can give 2 items, smell it and identify this is 1, this is 2, and then with the closed eyes he has to say this is 1 and this is 2. Very importantly, many patients, especially the males, may not be able to identify the smell. Females are more, they are able to identify the smells as different. So if they are able to differentiate the 2 smells, that this is 1, this is 2, that is sufficient. Again, remember, you have to use milder variety of the smell substances. You can use soap, you can use peppermint oil, you can use coffee, that's there, simple things which you can carry. Do not use anything that can effervescence and goes up, because if it effervescence and goes up, vaporizes and goes up, it will stimulate the trigeminal nerve and the sensation may be perceived because of that. Here we are checking the first cranial nerve that is checked. So you are going to do it with individual nostrils and then compare. So the most common causes are the local causes which cause anosmia, like rhinitis. It could be due to viral, it could be due to bacterial infection there, it could be due to sinuses, it could be due to serious conditions like atrophic rhinitis. The other conditions where there could be a tumor sitting on the olfactory nerve, that's there, like you have a frontal lobe tumor, that could be there. Viral infections, very common, produce anosmia like the COVID-19 which we had. And important thing that you have to remember, the smell goes hand in hand with taste. So anosmia is usually associated with dysgeusia or ageusia that is there. So neurological diseases where you have the smell getting lost early is Parkinson's disease, neurodegenerative diseases. It is a prodromal Parkinsonism. Before almost 10 years of the Parkinson's symptoms coming, they start developing anosmia that's there. It can be lost in peripheral neuropathy like Refsum's disease could be also seen. So these are common diseases. We have discussed the disorders of smell in a separate session. The next is the optic nerve. So optic nerve is the second cranial nerve, primarily related to vision. So we are going to look at the visual acuity, visual field, color vision and fundus examination. Most important is the field of vision as well as the fundus. Fundus examination is of practical importance that you have to understand. So visual acuity, you have the far vision, that's the Snellen's chart, and the near vision that we use the Jega's chart. So we are going to carry this and ask the patient to read, keep it at a distance of 6 feet that's there, and then you can ask him to read the letters, which letter is there, and then you grade the vision that is there. So visual acuity could be diminished in various causes. It could be cornea, cataract, you could have the medial problems, sometimes retinal problems can produce that. So visual acuity is something which you can grossly check. Coming on to the visual field testing, that's what we do, and the method that we're using is the confrontation method. This is going to be asked to demonstrate. So please remember, in the confrontation method, we are going to test the visual field very grossly. We cannot get the actual small defects. You cannot get the scotomas. You only can get hemianopias or hemianopsias that can be done. But this they ask you to demonstrate, so you have to know the visual field testing by confrontation method. So you sit in the front of the patient. Very importantly, you're sitting at a distance, arm span distance at the level of the patient. You're closing one eye, the patient has to close the opposite. So the same sided eyes are closed here, and then you ask the patient to look at your eye, not in the side. Patient should continuously look at your eye, and then you're going to get your moving finger from the peripheries. So you're going to do it in all the fields. So you can do it from the lateral part, you can do it from the nasal part, you can get it from the inferior part as well as the superior part that is there. So you are going to very importantly do it in one eye, then you're going to repeat it the other eye with your opposite eye getting closed. So here the patient should be able to tell you when he appreciates the finger movement. So if you look at the various fields, you have the temporal field, which is the largest field that you have, almost around 110 degrees you can see it. Followed by, you could have the superior field that is there and the inferior field, and the least is the nasal field. So if you can say that around 75 degrees is the superior, inferior is around 65 degrees, and the nasal field is around 45 to 50 degrees. That's the least. So you will be able to see that. So it's very importantly, we are going to get the moving objects. You can give a red color object also, because the peripheral retina is sensitive to color and moving objects. The actual field is got by what we do is the perimetry, which is done in, you'd have seen in your ophthalmology OPD, where you can get the actual small field defects, the scotomas can be got. By the confrontation method, we are going to get a gross defects. It's important in various disorders of where you have compressive lesions, possibly you could get hemianopias. Internal capsule lesion, you can get homonymous hemianopia. So again, we have discussed the various disorders that come under this in different sections, but if you remember the optic pathways, so you have the fields, the nasal and the retinal field, the nasal field and the temporal field that you have, which goes onto the opposite of the retina. So remember, the temporal field is going to the nasal retina and nasal field is going to the temporal retina there, and then from there the optic nerve is formed, goes on to the optic chiasma that's there here, and then from the optic chiasma you have the optic tract that is going to come to the lateral geniculate body, and from there the optic radiations going on to the visual cortex that you see. At each of the sites you can have lesions, and the lesions can produce certain defects. So if you look at the common diseases, if supposedly you have the lesion at the 1 here, that is the lesion point 1 that you're seeing here, you will have complete optic nerve is severed, so that eye you will have the complete loss of vision that's there. So the particular eye, if it is gone, you could have the complete loss of vision. So here you are saying the left eye is gone, so you would have a complete loss of vision in that eye. That is what you would get on the left eye. So in the lesion, if it is there in the optic nerve. Coming on to the optic chiasma, that's the lesion. Very characteristically bitemporal hemianopia, because remember the nasal fibers will cross there, the temporal fibers are going uncrossed, the nasal fibers are only crossing, you can see here. So the nasal fibers are involved, so you get the classical bitemporal hemianopia. This is usually seen with pituitary tumors or your cavernous sinus sometimes, or craniopharyngioma you could get there. The third site we are seeing is the optic tract before the lateral geniculate body, the optic tract that you are seeing there. So here if you get it is, you get whichever side, opposite side, homonymous hemianopia you get it. So if the left optic tract is involved, you get the right homonymous hemianopia, where you have the right sided temporal field and the left sided nasal field getting involved, because the fibers are crossing like that. As the lesion goes post geniculate, that is after the geniculate body, so the optic radiation is wide apart there. So you get quadrant anopia, that is if the lesion is in the upper part, you can get the upper quadrant anopia, and if the lesion is in the lower part, you could get the lower quadrant anopia. But please remember, if the lesion is on the left side, you get right quadrant anopia. So right upper quadrant anopia or right lower quadrant anopia. And if the visual cortex is finally getting involved, you get homonymous anopia, but macula is spared. So that's the difference between the lesion in the optic tract versus the primary visual cortex. So why does this macula sparing happen? One of the reason is that the macula is represented by bilaterally, okay, both the cortexes it's represented. Also the occipital cortex that is there has dual blood supply there. So it's very unlikely that macular region which has a dual blood supply, one-sided lesion will have these problems that could be there. So visual field defects, the gross visual field defects we can make out by doing the confrontation, but to get the smaller defects you would require to do perimetry, that's there. One of the common diseases like we get papilledema, again remember papilledema does not produce any visual field defect. Papilledema only produces a enlargement of the blind spot. So generally they do not have any visual field defect that you see. Coming to the color vision, so use the Ishihara's charts for that. So you would ideally require to carry these charts and identify the colors, the red, green, blue. Otherwise you can have cards of these three colors and ask them to identify. Majority of the diseases affecting the color vision are inherited. So they are the X-linked disorders that are there where you have these color blindness could be there. Some of the drugs like digoxin or maybe sildenafil or certain diseases, ethambutol, etc. can produce neuritis, which can produce certain specific type of color vision problems that could be seen. The most important part that they ask you to demonstrate is the funduscopy. So that's the important part that all postgraduates should know is the fundus examination. The technique of fundus examination is important. This is one of the techniques where where practice is needed. So how do you hold the ophthalmoscope? You should hold the ophthalmoscope where your finger should be there at the dial there, which can adjust the diopters, and then you're going to go to the distance, ask the patient to look at a distance there. If you're examining the right eye, you're going to stand on the right side of the patient, hold the ophthalmoscope in the right hand, that's important. But if you examine the left side, you're going to stand on the left side of the patient, very important. Left fundus, left side of the patient, you're holding in the left hand and you're going to look at the left eye. Whereas right fundus, right hand, right side of the patient, you're going from the right side. So you ask the patient to look at a distance, and then with the funduscope held properly, you're going to try to get the red reflex. You're going to focus there and then slowly come as close as possible to the eye and look at the fundus. You trace the arteries, you'll be able to go to the fundus there. And then if you ask to see the macula, you ask the patient to look at the light. So that time the macula will come to the center. Very important this technique. So generally if they ask you ophthalmoscope to do in the fundus examination, they are deciding whether you are going to pass or fail. It's that important there. So fundus examination is of very importance, the technique that you see. What you're going to observe there cannot be demonstrated. You can't, you will have to describe what you're seeing it. It's a blinded technique there, but the technique that you're using for funduscopy is very important, and you will have to demonstrate that. So in all patients, be it any system, fundus examination is mandatory. So practice this technique. Once you practice it, you will be able to do it smoothly. The important disease they ask you is papilledema. So papilledema could be due to various causes, and you have the various grades of papilledema that's there. So if you see, there is grade 1 to grade 5 of papilledema is there. So important here in the grade 1 is there is a disruption of the normal radial arrangement of the nerve fiber bundles. So there is a blurring of the margin. So margins are blurred, especially the nasal border is blurred. So the nasal border is blurred, and the spontaneous venous pulsations that you see, the vessels that you're seeing is the veins. So the venous pulsations that you see become decreased. So that is important finding that you see blurring of the margins with decreased venous pulsations. The grade 2 is where the nasal border as well as the temporal border is blurred. So both the nasal and the temporal borders is blurred. That is a circumferential blurring. Circumferential blurring of the margins is seen. Grade 3 onwards, there is an elevation of the disc along with the blurring of the margins in one or more retinal vessel segments. One or more retinal vessel segments that is there. Grade 4, where you have the obscuration of all the segments. And grade 5 is where grade 4 is there along with complete obscuration of the disc. So complete obscuration of the disc, that is what we call it as grade 5 papilledema. Now if you see here, this is the complete disc is obliterated. All the retinal segments, you see 1, 2, 3, 4 are all blurred. The disc margin is not seen. This is how you get the grade 5 papilledema. So again remember, even with grade 5 papilledema, you do not find any visual field defect. So coming on to the causes of papilledema, the papilledema is the hallmark of raised intracranial tension. So any condition where you have a raised intracranial tension, you will have papilledema. So the common conditions could be tumors, that's the most common causes, or the space occupying lesions. It could be an abscess, it could be a bleed, it could be tumor that could be there, or an AV malformations. You could get papilledema other than space occupying lesion in meningitis and encephalitis. So you could get it in meningitis, encephalitis. It could occur due to encephalopathies, like you could see it in hypercarbia whenever the carbon dioxide is very high, or natremia that could be there. Could get due to metabolic encephalopathy. So you could get that in that conditions. Very commonly in hypertension, accelerated hypertension, you should look at the fundus. So that would mean that there is an encephalopathy. It's a sign of hypertensive urgency that is there. Anoxia, that can produce that. Very important cause there. Very, very important metabolic causes that you have to remember where it produces papilledema is hypercalcemia and hypoparathyroidism. You could get this in GB syndrome, very important, GB syndrome. GB syndrome, fundus can show problems like papilledema that could be there. Hydrocephalus, very important. Especially the non-communicating hydrocephalus can produce the features of papilledema. Sometimes the patients can come with headache and you see the papilledema, but then when you see the pressures are very much normal that you see, or you might find that the ventricles are dilated, but then they may not be having CSF pressure. This is what we call it as pseudo-tumor cerebri, which could be due to various drugs, could be due to steroids, could be due to tetracycline, antibiotics, etc. What we call it as a pseudo-tumor cerebri condition where you could get papilledema. Fundus gives us a lot of clues for various other diseases, like if you see there choroid tubercles, you could get these tubercles, which could be a feature that could be seen there. So you could get because of that. You could get focal arteriolar narrowings that could be there. Now this could be due to blocking of the arterioles, could be due to hypertension, could be due to other conditions like procoagulant states could be causing it, focal ischemias. You could get copper wiring, you can see that again a feature of hypertension, very classically you see that copper wiring that you can see there. Proliferative diabetic retinopathy, you could get there, so you could see that various retinal photocoagulation points there, you could see the bleeding that you could see there. This is a very characteristic feature that you see there. You could get the AV nipping where you could have the arterial and venous, so normal the vessel you see is vein, but the arteries become running over that and you could get this AV nipping or the angulation or the gun sign that you see there. You can get cotton wool spots, macular edema can be seen there, you could see the classical macular star, could be seen with diabetic retinopathy and sometimes with hypertension also. The stages of hypertensive retinopathy, you have the Keith-Wagner staging, where you have the 4 stages that you see. So you see the focal arterial narrowing, that's in first stage, the AV nipping or the gun sign or the Salus sign. Then you have the copper wiring that you see there, and finally you see the silver wiring as well as the papilledema, which would be seen in grade 4 hypertensive retinopathy. Various opportunistic infections like cytomegalovirus, toxoplasmosis, you could get in the fundus. You could get infective endocarditis, rot spots in the fundus. You can get subarachnoid hemorrhage. You get the classical subhyaloid hemorrhage that you see. That's the Terson syndrome that you can see, which you could get in case of fundus. So fundus gives us a lot of clue, and fundus examination is mandatory in all your exam cases. So you have to practice this technique. The 3, 4, 6 cranial nerves basically are dealing with the oculomotor, the functions of the ocular movement that is there, and each of them have various abnormalities. The 3, 4, 6 we have discussed diplopia, etc. in a separate section. So what are the things that we are going to examine? You're going to examine the eyelids, that's important. Look at the position of the eyeball, look at the extraocular movements, look for the pupils, the pupil size, shape, reflexes, and then look for nystagmus, very important. So this is the headings that you're going to examine in the patient. So eyelid, look for ptosis. So you could have neurogenic ptosis where you have third nerve palsy that can produce that. You could get mechanical ptosis secondary to edema that could be there. You could have ptosis because of muscle disease. You could have ptosis due to neuromuscular junction diseases, bilateral, unilateral. So various causes we have discussed this. So if you look at the ptosis and the pupil size, so combination, you could have the small pupil, that is the miosis, or you could have the large pupil. So ptosis with miosis, ptosis with mydriasis. So if you have ptosis with miosis, your diagnosis is very clear, it is Horner syndrome. Whereas ptosis with mydriasis is a third nerve palsy, especially compressive lesions of the third nerve produces this. Now, if you have ptosis with normal pupils, normal pupillary size. So, what are the causes? It could be due to myasthenia gravis, most common, myopathies, pupil sparing third nerve palsies, that is the infarction of the third nerve, not compression, infarction of the third nerve, and rarely you could get it in case of GB syndrome. So, this is the differential diagnosis based on the ptosis and the pupil size that you have to make out. Sometimes you could have reversible ptosis, very importantly, what we call it as an ice pack test. Okay, you have the ptosis there, and then you are placing the ice pack test, or what we call it as an ice on ice test. So you place ice, keep it for 5 minutes there, and then measure the aperture. It classically improves. You can see there the ptosis here, and it has significantly improved after ice that has been placed. Very, very important. If there is a more than 2 millimeters improvement in the aperture, that would suggest that this is myasthenia gravis. It's a very, very important sign that can be achieved or can be suggestive of myasthenia gravis, which produces a fatigable muscle weakness. Coming on to the next abnormalities that you could have. So you could have exophthalmos, where there is a proptosis. So exophthalmos is bilateral, so proptosis, which you see, classically seen with hyperthyroidism, which could be usually bilateral, as you see in Graves' disease. You can get unilateral conditions which produce exophthalmos or proptosis. The common conditions could be related to cavernous sinus, thrombosis, carotid cavernous fistula, orbital mass lesions, sphenoid wing meningioma, and a very common disease which we saw during the COVID pandemic, mucormycosis. The orbital mucormycosis could be there. And hyperthyroidism to begin, okay, Graves' disease beginning is always unilateral that you could see. In ophthalmos, that is where there is a relative posterior displacement of the globe with the normal size. The globe is beyond the margin. Could be seen with Horner syndrome. Because of the ptosis, it looks that is inside. It could be due to microphthalmia. Sometimes the size of the globe itself is post-traumatic. It could be shifting backwards. Marfan syndrome, or you have the Duane syndrome, where you could get the enophthalmos, or it could be part of the phthisis bulbi, where the globe is destroyed. So these are the various conditions where you can get enophthalmos that you could see. Coming on to the extraocular muscles, so you have the 6 extraocular muscles, you have the 2 obliques and the 4 rectus. So if you see superior rectus, inferior rectus, superior oblique, inferior oblique, medial rectus and lateral rectus, each of them have the various functions. The medial rectus primarily function is the adduction, the lateral rectus is the abduction, it takes out. They are the primary, they don't have any other secondary or tertiary function. Whereas the superior rectus is a predominant elevator, it is an intorter as well as adductor. Inferior rectus predominantly is a depressor, but it is an extorter as well as an adductor. So please remember, all recti are adductor except lateral rectus, which is an abductor. Coming on to the superior oblique, primary function is intorsion, but it also does depression and abduction. Whereas inferior oblique primary function is extorsion, but it also does elevation and abduction. So remember, again the obliques are abductors. So what are the various abductors? Superior oblique, inferior oblique as well as lateral rectus, whereas all the other recti are adductors, that is there. What are the elevators? Superior rectus and inferior oblique are elevator. What are the depressors? Inferior oblique and inferior rectus and superior oblique are depressors that we see. So if you look at the primary movement where you check for, so superior rectus, you ask the patient to look laterally and upwards. So laterally and upwards, that is superior rectus that you are seeing there. Inferior rectus is laterally and downwards. Look laterally is lateral rectus, look medially is medial rectus. In the medial position, looking up is inferior oblique and looking down is superior oblique. So superior oblique, you are looking at the tip of your nose. So remember, the nose is here, this is the position of the nose. So you are looking at the tip of your nose, you are looking at the superior oblique. Lateral rectus, you are looking out. Important because the superior oblique is supplied by the 4th nerve and the lateral rectus is supplied by the 6th nerve. All the other cranial nerves are supplied by 3rd nerve itself. So this is the primary positions and how do you check for individually. Before we go on to the ophthalmoplegia, please remember that in the 3rd nerve, if you see 3rd nerve here, the fibers which supply the pupils are located in the periphery. So this you see there, the fibers are located in the periphery, whereas the fibers which supply the muscles are supplied in the center, that's there. So the blood supply is there, for the center is separate, the blood supply from outside is separate. Now whenever we have a compressive lesion, a tumor or a bleed that is there, it compresses the 3rd nerve from top. So the pupillary fibers are affected in the primary position, that's there. So in a compressive lesion, the pupillary fibers are separate. Whereas if there is a vascular problem, vasculitis or a diabetic vasculopathy, the vessel is getting blocked, this vessel is getting blocked. They have supply only the motor, whereas the pupillary fibers are supplied by blood vessels which is there in the side. So the pupils are spared. So in surgical ophthalmoplegia are pupillary involving ophthalmoplegia. So dilated pupil with ophthalmoplegia, it's a compressive lesion, surgical ophthalmoplegia. Whereas medical ophthalmoplegia like diabetes, vasculitis, myasthenia gravis, there the pupils are spared. That is what we will have to remember. So when we examine the nerve, we are doing 3, 4, 6 together. So we do this H. So start from the center, go to the side, go up, go down. So going out, lateral rectus, superior rectus, inferior rectus. Come back, medial rectus, superior, inferior oblique, superior oblique. So that's how you check for both sides you are going to check. And again remember, medial rectus and lateral rectus will be acting synergistically. You are having the superior oblique and inferior rectus which is going to act synergistically that you would be seeing. So various types of ophthalmoplegia, as I told you, when you have the 3rd nerve involvement, we call it as pupil sparing ophthalmoplegia and pupil involving ophthalmoplegia. So as we said, the pupil involving ophthalmoplegias are the compressive lesions. So they are the surgical causes or the compressive lesions. So what could be the causes that could come under that? Could be a hemorrhage, could be a tumor, could be an aneurysm. So most common cause we see is an aneurysm. the posterior communicating artery aneurysm, the PCOM aneurysm that's there, or the ACOM aneurysm. So aneurysms that is there, tumors that's compressing, that is what is going to be there. The pupil sparing are the medical causes, as we said, and the important cause which produce pupillary, this one, diabetes is an important cause, vasculitis, myasthenia gravis, myopathy. So these are the third nerve palsies that could be there. The fourth nerve can get involved due to nuclear lesions. It could be lesions, third and fourth cranial nerves are located in the midbrain. So midbrain lesions you could have. You could have the Benedict syndrome, you could have the Claude syndrome, you have the Weber syndrome where you could get that. Sixth nerve located in the pons. Again, remember, pontine lesions can produce there. Millard-Gubler syndrome could be there, or you could have the Raymond-Sisson syndrome where you could get the sixth nerve involvement. But again, remember, sixth nerve has a very long course. It comes up there. So any cause of raised intracranial lesion, raised ICT, will compress the sixth nerve because it has a very long course that's there. So it's otherwise called as a false localizing sign. You could see that there could be a false localizing sign. So here is a patient where you can see that the patient is having diplopia, has come with diplopia. So if you look at the examination of the part of the eye, you can see the left eye, all movements are preserved. The patient is able to look up and down, look in and in. You can see here, but on the right side the patient has a third nerve palsy. So because the third nerve palsy, the only functions that are preserved if third nerve is there, lateral rectation, so this is preserved, and you can see that the patient is able to get the superior oblique function also, so you can see that. So and you see here in the primary position you have a complete ophthalmoplegia where the ptosis is there as well as the pupil is dilated. So this was basically because of the aneurysm that was compressing the nerve. So as we said there, if the lateral rectus is affected, so the movement affected is abduction, so the squint is convergent and it is maximum when looking lateral rectus. Whereas medial rectus, if the adduction is affected, the maximum diplopia happens medially and you have a divergent squint that is seen. So third nerve, you have a divergent squint, what you saw in the patient. If the superior oblique is affected or the fourth nerve is getting involved, so what is not able? Downward and inward movement is not available, and the diplopia will be maximum when the patient looks downwards and inward. It is an uncrossed hemiplegia. Please remember, the crossed diplopia is only with medial rectus, superior rectus and inferior rectus. All the adductors, adductors which are there. So that is where you can get the uncrossed hemiplegia. All the rest is cross that you can see. Inferior oblique, the maximum movement that would happen is up and out. When you're looking there, that can be there. Up and looking medially, that's there. The superior rectus, very important, up and out. So up and out, that's where you can get the maximum. And inferior rectus is where you look at the down and laterally. So this movement is where it is getting affected. So if you look at the third nerve palsy, the patient will have ptosis, they will have dilated pupil, and the patient will be unable to adduct the right eye, larger angle of the squint, double vision which is further apart. Fourth nerve palsy, you may not have a squint when the patient looks out, but when the patient starts looking inwards, they will have a squint here. You can see that the patient is not able to do this movement and they have diplopia. Whereas sixth nerve palsy, lateral rectus palsy, if you see here, the patient is not able to look at outwards and they will have squint when they attempt to look outwards that you see. Once you've done the extraocular movements, look at the pupils. Pupils can be examined in the beginning itself. So you're looking at the pupils, the size, the shape and the pupil. So you have mydriasis or you could have meiosis. So it could be large pupils, what we call it as mydriasis. So mydriasis can be either unilateral or bilateral. So various causes you should remember. So if it is unilateral mydriasis, sometimes it could be physiological. Very rarely it could be that. Sometimes pharmacological, you could have certain mydriatic drugs which can be put. Third nerve palsy produces unilateral. Adistonic pupil is a dilated pupil, adistonic pupil. Uncal herniation, very important cause which produces a unilateral dilated pupil on the side of the hemiplegia, what we call it as the Kernahon's effect or the Kernahon's notch and effect that could be there. Sometimes you could have unilateral mydriatic pupil due to sphincter paralysis, just the traumatic sphincter, and rarely it could be due to ocular siderosis, deposition of iron or hemosiderin that's there, that could be there, and sometimes due to the iris ischemia. The iris itself is ischemic, so it does not dilate on one side. Coming on to causes bilateral. So what are the causes of bilateral? Most common cause is pharmacological, when you put some drops mid-rheatics. Physiological is always unilateral, so remember pharmacological is almost always bilateral. It could be due to Parinaud syndrome, dorsal midbrain syndrome. You have bilateral dilated pupil, you have the convergence nystagmus nystagmus that could be seen there, Collier sign could be seen. Also it could be meaning brainstem death. So bilateral dilated pupil not reacting, Dolce negative is a feature of a brainstem death that you see. Coming on to meiosis, so where the pupillary size is less than 3 millimeters. So again it could be unilateral or it could be bilateral that you see there. So various causes of myotic pupils that is there, very small pupils. What are the causes? So unilateral, it could be physiological sometimes, pharmacologically rarely. Very important cause, remember, is Horner syndrome. And you could get it in anterior uveitis, where you could have it, and rarely the patients can have a long standing addes. Remember, addes is always a dilated pupil. Long standing addestonic pupil can be small. Coming on to the causes where you have a bilateral myotic pupil, senile, very important. As you age, you can get the senile pupil that's there. Argyll-Robertson pupil that you see in syphilis is a bilateral small pupil. Drugs, that is pharmacological, myotics which you use, various treatment of glaucoma that could be seen. You could get meiosis in certain other diseases like leprosy, very important. Lepromatous, you could get that, syphilis, leprosy I said, myotonic dystrophy, that is one thing, and you could have congenital microchoria. It could be by birth that could be seen. So these are the conditions where you could get bilateral small pupils that you see. The other two important things that you have to remember is the light reflex and the accommodation reflex. So light reflex, you have the direct right reflex and the indirect right reflex or the consensual light reflex that you see. So you shine the light from one side, you expect constriction of the pupil. On the same side, that's the direct reflex. On the other side also it happens as consensual. So it goes from the sphincter pupillae, it is getting activated. So through the nerve it is going through the tract, reaches the lateral geniculate body, then goes to the Eddinga-Westphal nucleus, pretectal nucleus and the superior colliculus, and comes back. That's the crossing over that's happening here at the midbrain, and then comes back through the short ciliary nerves, through the part of the oculomotor nerves, and completes the sphincter pupillae that is seen. So light reflex is how that you do it. Coming on to the accommodation reflex. Now accommodation reflex is where you would have meiosis, convergence, and the anterior curvature of the lens also will increase. Now this is where you ask the patient to look at a distance and then ask him to look at the tip of his nose or get a finger very close. So what he has to do, he has to converge. So medial rectus should act, bilateral medial rectus. Meiosis, so your entire pupillary reflex pathway will happen, as well as the lens will become more conical. So it becomes a relaxation of the ciliaris muscle should happen. So now here, other than the light reflex pathway, the impulse goes to the frontal eye field. So from the frontal eye field, it is going to the callicrine cortex. You have the superior longitudinal fascicle that is going to be there. And from there, there are certain impulses which are going to travel down through the posterior commissure. The entire pathway of the light reflex is there, but again it has to act on the convergence center. So convergence center that is there, and that will make sure both the medial rectus is acting together. Remember, when normally one medial rectus acts, the opposite lateral rectus should act. So you have what we call it as a horizontal gaze center that has to be suppressed, and the convergence center has to be stimulated so that both the medial rectus will act together and there will be convergence. So that's the pathway that you see. The one common abnormality that you get is what we call it as an Argyll-Robertson pupil. Now, Argyll-Robertson pupil classically described for syphilis. So, neurosyphilis, where you get the tabes dorsalis, that's where you see there, where accommodation reflex is preserved. So, accommodation reflex is preserved, the pupils become smaller when they accommodate, but light reflex is lost. So, when you shine the light, there is no response, but when they converge on its own, there is meiosis. So, this is what we call it as the light near dissociation. So, where the light reflex is lost, but the near reflex is preserved. So, in case of syphilis or leprosy, certain conditions, it is bilaterally present. So, you can have a bilateral Argyll-Robertson pupil. Earlier syphilis was seen, now you can get it in diabetes, or you could see any lesion in the pretectal region can produce this light near dissociation. But please remember, the most common cause for the light near dissociation is when you are examining the patient with a very dim light, the torch light is not so proper, or you are examining the patient in a very, very bright room, already the pupil has become myotic. When you put a light, it won't become. So, those are the two common causes for light near dissociation, followed by syphilis, diabetes. It could be due to midbrain lesions, especially where the pretectal region, if there is a lesion there, you can have a Argyll-Robertson pupil that you could get. Reverse Argyll-Robertson pupil, where in this accommodation reflex of one pupil is absent. So, accommodation reflex is absent in one, classically seen in case of diphtheria, or there is a tumor at the corpora quadrigemina. That site, if there is a tumor, you could get the pseudo or the reverse Argyll-Robertson pupil. The next pupillary abnormalities that you would require is the Wernicke's hemianopic pupil. Now, this is the lesion in the optic tract. So, if you have a lesion in the optic tract, what happens there? When you shine the light on one of the fields, they have hemianopia, isn't it? So, when you shine the light in that part of the hemianopic pupil, the pupil will not constrict. So, that is called as a hemianopic. So, the patient has hemianopia, because of that the light is not perceived. It is in the opposite nasal, if you put it, it will be perceived. So, Wernicke's hemianopic is usually seen with optic tract lesions, could be due to internal capsule lesion also. Next, you have the Eddy-Stonic pupil. Now, Eddy-Stonic pupil is a condition where the reaction to light is absent. So, light reflex is absent usually here, and the pupils is usually larger. So, you have mydriasis that you see there. The accommodation reflex is slow, very, very slow and tonic. That is what is seen. Usually seen in young women, and they will have absent knee jerk also, and usually it is unilateral. So, that is what we call it as the Holmes-Eddy syndrome. Especially other than knee jerk, if all the other reflexes are absent or diminished, we call it as Holmes-Eddy syndrome. Now, very importantly, it constricts with pilocarpine. So, moment you put pilocarpine, that also very small amount, that is 0.125% of pilocarpine, if you put, the pupil will constrict. So, that is how you identify the Eddy-Stonic pupil. Long standing Eddy-Stonic pupil becomes myotic. What we call it as the little old eddy. As it becomes for a long time, the patients, as they age, it becomes myotic. So, that is the Eddy-Stonic pupil. The next important pupillary abnormality is what we call it as a relative apparent pupillary defect, RAPD, afferent pupillary defect, or otherwise called as the Marcus gun pupil. So, Marcus gun pupil, very important. Now, here remember, this is demonstrated by doing something called as a swinging flashlight. Now, here this is very, very characteristic. You have to do it rapidly by swinging the flashlight. It's a optic neuritis, okay. Optic nerve is getting involved, classically in multiple sclerosis or any optic neuritis, whichever condition, most common will. What happens when we shine the light on the affected side? So supposedly you have normal pupils 3 millimeters, both sides, right and left. So what happens when we shine the light? This becomes 2 millimeters. This also becomes 2 millimeters when I am shining from the right side. That's a normal response, right? Now supposedly there is an optic neuritis on the right side. What happens? This pupil is remaining like that. The opposite pupil also will remain like that. Now when I rapidly go on to this side, I am shining the light from the left side. Okay, left side, what is going to happen here? Left side optic nerve is normal. So moment I shine the left sided light, the left eye will become 2 millimeters. Right eye also will become 2 millimeters because of the consensual reflex from that. Now if I rapidly get it to the right side and now constrict, what happens? Instead of constricting, this is normally 3 millimeters, no? But it has become 2 millimeters because from the opposite side stimulus has come. But this side no stimulus, so instead of constricting, this pupil will now become 3 millimeters. So it looks opposite, like instead of constricting when you're putting a light, it becomes dilated. So it's called as a lag that is there. So it's a very dynamic absence. So remember, the eye which is affected, instead of constricting, it becomes dilated because of the opposite side stimulus which is already constricted. So that is very important. You have to do it by rapidly moving, swinging flashlight. When you constrict on one side, instead of constricting, it becomes dilated. That's because of the stimulus on the opposite side that you have to see. Now it is classified as various grades. So trace APD, where there is no initial constriction, but then it escapes to intermediate position. 1 to 2 plus apparent pupillary defect is where there is a dilation, and 3 to 4 pupillary defect where immediately when we shine it becomes dilated. When not, you don't require opposite side stimulation. A normal stimulus from that side itself has made it constrict. Instead of dilating, constricting when you show, it immediately dilates on the first instant. That called as 3 to 4 plus apparent pupillary defect. Very important sign of optic neuritis that we have to see. Next, you look at the Hutchison's pupil. This is seen in comatose patient. Dilated pupillary reflex is lost, dilated pupil, seen in herniation, especially the uncal herniation you could get. Next, you have the hippus. Hippus is nothing but alternating constriction and dilatation which is happening of 2 millimeters or more, that is happening. Classically seen with the pupillary, you could get it in brainstem lesions, could be there in aconite poison. Commonly, you could get it in myasthenia gravis also. It's also called as pupillary ptosis. You could get it in myasthenia gravis also. Tectal pupils, where you have a large pupil with light near dissociation, it's called as tectal lesions, usually midbrain lesions. That is your classical Parinod syndrome you could get there. So that's called as a tectal pupil that you see. So whenever we see a pupil, obviously look for light reflex, look for the anisocoria that is there. If the anisocoria is more in light, then obviously it's more you're looking at, in the light, more in light. More in dark means we're looking at the Horner syndrome. Horner's pupil always look it in dark, whereas third nerve palsy we look it in light. So whenever it is more in light, we are looking at the third nerve. First thing that we are going to look for is apply pilocarpine. So if it is negative, increase the pilocarpine dose to 1%. If the large pupil constricts, then we know it is a third nerve palsy. So please remember, the third nerve palsy get constricted if you use a larger dose, 1% pilocarpine. Now if there is an iris damage that you see and then you find that after applying 0.1% itself the pupil is dilated, that is adistonic pupil. So adistonic pupil 0.1% is enough to dilate it. And if 1% dilated also, there is no importance, that is a pharmacological mydriasis, could be senile also. Now if the anisocoria is more in dark, we are looking at the Horner syndrome. So the first test that we are going to put is 1% epreclonidine. If it is not, that means it is simple anisocoria. If it positive, that means the pupils dilate, we are looking at Horner's. And then once you put epreclonidine, next you can put phenylephrine. If the phenylephrine 1%, if it is positive, that means it's a postganglionic Horner's or it's a preganglionic Horner's. Let's briefly discuss about Horner's syndrome, because this is a very common question asked. You have to know the types of Horner's and how do we decipher which order Horner's is. So when you look at the Horner's, so you have the components. The ptosis is there, there is meiosis, there is inophthalmos, anhydrosis, and loss of ciliospinal reflex. So these are the various things that are components of the Horner syndrome that you see. So if you look at what is the cause for ptosis, so ptosis is basically due to the denervation of the Muller's muscle. The meiosis is due to the denervation of the dilators. Inophthalmos basically is because of the narrowing of the palpebral fissures, and anhydrosis is basically because of sympathetic denervation. So these are the components of the Horner syndrome, and you should know why it is. Now before we go on to the localization of Horner syndrome, we have to know the pathway of the Horner's. So you have the sympathetic pathway, which is going to come from the posterolateral part of the hypothalamus. So the fibers are going to come down through the brainstem, the medulla, the pons, the midbrain. It's going to come from there. And please remember, it's located in the lateral part of the brainstem. So lateral medullary syndrome, lateral pontine syndrome, lesions involving the angles there is where the these sympathetic fibers can get involved. So you get it down there and it comes through the spinal cord till to T2. So T2 it is going to come in the cervical, CA-T2. You have a ciliocenter spinal center of Budge. That is where it is going to come and land up there. That's where the first order neuron is going to stop. So the first order neuron is going to stop here. That's from the hypothalamus to the ciliospinal center of Budge. From the ciliospinal center of the Budge, the second order neuron is going to come, and this second order neuron is going to go to the superior cervical ganglion. The superior cervical ganglion is where the second order neuron will stop. From there, the third order neuron is going to go from the superior cervical ganglion. It is going to through the third nerve, so along the ophthalmic artery there, and the branches through the nasociliary nerve where it goes to the pupillary dilator and the lacrimal glands, and the Muller's muscle is getting supplied there. It is important that you have to remember that the pseudomotor fibers, very important, the pseudomotor fibers. What are the pseudomotor fibers? Are the fibers which supply the anhydrosis, sweating that's there. That is given prior to the ganglion. That is going to the ganglion before that. So ganglion is here. So if the third order nerve is getting involved, so please remember the pseudomotor anhydrosis is not a feature. Anhydrosis will be only seen in first and second order organs. Clear? That is the path that you have to remember. Now remember certain structures that are there, which are the lesions which will cause that, you should remember. So remember, as I told you, hypothalamus here, the entire brainstem, the medulla, the pons, where you could have that. Cervical cord, you could have lesions in the cervical cord that could be there. Now second order, remember it's going through the lung here, subclavian vessels, Pancoast tumor can come, cervical rib can come, any lesions here, lymph nodes here. Next you have the carotid artery, along the carotid artery that's there. So carotid, dissection of the carotid can cause nerves. You could have glomus jugular tumor that's there because the IJV is there, located there. Then you have the cavernous sinus there. Superior orbital fissure is there. You could have problems in the in the orbital apex that could cause there. So various lesions can produce lesions of the Horner's that could be seen. Now Horner's can be classified into two types. One is called as the central Horner's and the peripheral Horner's. The peripheral can be preganglionic and postganglionic. Central is always preganglionic Horner's. First order, second order, third order. Central is first order, preganglionic peripheral is second order, and postganglion peripheral is third order Horner's that is there. So you will have to know the differentiating features of each of these Horner's and the cause for each of these Horner syndrome that you have. Now the first order Horner, You remember the first order neuron that's coming. It is from the hypothalamus to the C8T1 where the ciliospinal center of budge is there. Now you will have associated features of the long tracts. So long tracts are involved. So either patient can have hemiplegia, they can have hemisensory loss, they can have lateral medullary, dizziness, vertigo, cranial nerve involvement, they could have transection of the spinal cords that could be seen there. Very, very important, what are the features that could be seen? When you put hydroxyamphetamine, dilates both the pupils. Next you use phenylephrine, again dilates both the pupils. Then the cocaine. Horner's pupil fails to dilate. So Horner's pupil fails to dilate by putting cocaine is a very characteristic feature of first order Horner's that you see. Coming on to the second order or the second Horner, where it's there in the from the ciliospinal joint till the superior cervical ganglion that's there. So what are the causes that could be there? Lung mass, lymph node, cervical rib that's there, neck mass, thyroid, neck surgery, neck injury, bony spurs that could be there. So you would have lesions of that, you could have lung tumor features that could be seen here. Again, you put hydroxyamphetamine, both pupils dilate. Phenylephrine, both dilate. Cocaine, when we put, Horner's dilates. When you put cocaine, the Horner's pupils dilates purely. So that's how you diagnose the preganglionic Horner's. Coming on to the third order Horner. So here it could be due to cavernous sinus thrombosis, it could be due to migraine, it could be due to carotid artery, this is there. Very, very important feature, sweating is preserved. Very characteristic because the pseudomotor fibers are given before the ganglion. Now what happens if you have hydroxyamphetamine, you have phenylephrine, cocaine, all are putting here. Again remember, cocaine is the diagnostic where Horner's poorly dilates, doesn't dilate. Phenylephrine, very important, Horner's pupil dilates here. So postganglionic Horner's, phenylephrine when we put, it dilates. What about hydroxyamphetamine? The Horner's pupil will dilate. Usually, Horner's pupil will dilate very less with cocaine compared to the hydroxyamphetamine. But phenylephrine, if it dilates, it is always peripheral Horner's that you have to see. So this is the classical Horner syndrome. You can see that the left-sided Horner's, there is ptosis, meiosis, there is loss of sweating on that side. It's a peripheral Horner's. You can see that there is a scar here that has produced the Horner. It was cut above the superior cervical ganglion. So it is a peripheral Horner's that you have to see. Coming on to the 3-4-6 cranial nerve involvement, you call it as ophthalmoplegia. So ophthalmoplegia could be various types of ophthalmoplegias. So we classify the ophthalmoplegias as supranuclear ophthalmoplegia. It could be nuclear ophthalmoplegia or the infranuclear ophthalmoplegia, that is LMN. And one more type is what we call it as an internuclear ophthalmoplegia. That is specific for, otherwise all cranial nerves is either supranuclear or nuclear infranuclear, only two types, facial or any, but 3-4-6 you have one new called as internuclear. Now supranuclear ophthalmoplegia is where the 3-4-6 cranial nerves which are located, the supranuclear, the corticonuclear fibers are getting involved. So bilateral lesions, if there is, you could get that involvement. Corticonuclear fibers, we call it as gaze palsies, up gaze palsy, down gaze palsy, lateral gaze palsy, horizontal gaze palsy, that is supranuclear. Nuclear or infranuclear is either the 3-4-6 cranial nerve nucleus or the nerves is getting involved wherever it's a tract. Now internuclear is where the MLF or the PPRF is getting involved. So MLF and PPRF connect one-sided third nerve, you remember the medial rectus is connected to the lateral rectus on the other side. So medial rectus is the third nerve, lateral rectus is the sixth nerve. So one-sided third nerve to the opposite side, sixth nerve is collected by the MLF or the PPRF that is there, and involvement of that produces a specific neurological condition called as internuclear ophthalmoplegia. Let's discuss a little more detail in these. Before we go, one more classification called as internal ophthalmoplegia, external ophthalmoplegia, and total ophthalmoplegia. So total is 1 plus 1. Now, if there is internal ophthalmoplegia, that means the paralysis of the constrictor pupillae and the ciliary muscle. External ophthalmoplegia means extraocular muscles, and total is where extraocular muscles plus constrictor pupillae and ciliary muscle is all involved. That's called as total ophthalmoplegia. Now coming on to the supranuclear ophthalmoplegia, where there is a gaze palsy. So various types of gaze palsies you could have. So you have the vertical gaze palsies that come here, and the vertical gaze palsies, you have two major types that you have. One is called as the upward gaze palsies and the downward gaze palsies, and then you could have the combined upward and downward gaze palsies. Up gaze palsy is very commonly seen in case of Parinaud syndrome. Parinaud syndrome is a dorsal midbrain syndrome, lesion above the superior colliculus, where you have the up gaze palsies, UPMSC. That is up gaze palsies, you have upbeat, you have the mydriasis that is there, and the retraction nystagmus, retraction nystagmus, or the Collier sign that you could get. You could get it also in PSP, progressive supranuclear palsy. You can get it in Parkinson's disease. You can get it in Wernicke's encephalopathy, and classically thalamic hemorrhage. You get the eyes go down, what we call it as the sunset sign, classical of thalamic hemorrhage. The down gaze palsies commonly seen with Huntington's chorea, Niemann-Pick disease, OPCA, that is olivopontocerebellar ataxia, progressive supranuclear palsy, and Parkinson's disease. So remember, Parkinson's disease, progressive supranuclear palsy can have both up gaze as well as down gaze palsies that you could see here. That is the combined. So as I said, PSP, Parkinson's disease, and bilateral frontal lobe lesions can produce the both up gaze and down gaze palsy. So these patients will have recurrent falls when they climb down stairs. So this is the classical appearance where you have the patient is not able to see up. So the eyes are gazed, fixed, staring look, the classical reptilian stare. You can see that the frontal muscles is very much contracted. You can see the procerus acting here, very characteristic of PSP that you could see. Coming on to the internuclear ophthalmoplegia. So here the medial longitudinal fascicle is what is importantly involved. So you have the third nerve on one side, you have the sixth nerve on the other side. So you have the third nerve on one side and the sixth nerve. So there are a group of interneurons which connect the third nerve on one side to the sixth nerve on the other side. What we call it as the medial longitudinal fascicle. So this is very important because once the medial rectus acts, the opposite side lateral rectus should act. Only then you could get the horizontal gaze that can prop. So this group of interneurons is what we call it as the medial longitudinal fascicle, and when you have it in the center, we call it as the PPRF, parapontine reticular formation that is there. That is where you could see. Now, what happens if this MLF is involved or the internuclear ophthalmoplegia? What are the classical features that you could get there? Here, there is an impaired adduction of ipsilateral eye. So, adduction is impaired. So, that is what we get. And you have the abducting eye nystagmus on the contralateral eye. So, abducting nystagmus in the contralateral side. So, supposedly you have a right-sided MLF involvement, you will have impaired adduction in the right eye, and the left eye will show an abducting nystagmus, because when this side adduction should happen, the other side should abduct, right? It should abduct, but that is not going to happen. That is what is happening. We call it as a internuclear ophthalmoplegia, loss of ipsilateral adduction, adduction, and abducting nystagmus in the contralateral eye. Very characteristically seen with MLF involvement, and MLF is classically involved in multiple sclerosis, medial medullary syndrome, ischemia, etc. could be seen. So this is the characteristic appearance. If you see here, this is the medial longitudinal fascicle and the parapontine reticular formation, which is connecting the 6th cranial nerve nucleus on one side to the 3rd cranial nerve nucleus on that opposite side to allow the horizontal gaze that would be there. So various types of internuclear ophthalmoplegia are seen. So you classify internuclear ophthalmoplegia into superior internuclear ophthalmoplegia and inferior internuclear ophthalmoplegia. So superior is usually having in the brainstem lesions, you get this, whereas the inferior lesions are usually present in the pontine lateral gaze center, affecting usually the 7th nerve nucleus getting affected. The superior one is seen in the brainstem lesions. It is called as the Lermit syndrome, whereas the inferior INO is what we call it as the Lutz syndrome, Lermit syndrome and Lutz syndrome. Now you could get pseudo internuclear ophthalmoplegia where the nerves are not getting involved, but you could get this ophthalmoplegia like features classically seen with myasthenia gravis and Miller-Fisher syndrome, produce pseudo internuclear ophthalmoplegia that you see. Two other syndromes that you have to remember with internuclear ophthalmoplegia. One is called as the Webino and the other one is called as the Wemino. So Webino stands for the wall-eyed bilateral internuclear ophthalmoplegia, where you have bilateral medial longitudinal fascicle is involved and the bilateral medial rectus nucleus is getting involved. So both eyes will go as a walled eye bilateral ophthalmoplegia, pupils dilated. Next is the Wemino, where you have unilateral MLF involvement plus unilateral medial rectus nucleus involved. That is called as a wall-eyed monoocular internuclear ophthalmoplegia. So monoocular, here it is bilocular. So Webino is bilateral INO, whereas Wemino is unilateral INO that you see. Now coming on to the various syndromes where you have the involvement, oculomotor nerve involvement in the brainstem, especially the midbrain, you could get involvement like Weber's, North-Nagel's, Benedict's and Claude's. Abducens can classically get involved in the Raymond-Seston and Foville's and Mobius. Subarachnoid space, the 3rd and 4th cranial nerve get involved. The 6th is less commonly to get involved. As it comes together, if you see the petrous apex, the Dorello's canal, the 6th cranial nerve can get involved there. In the cavernous sinus syndrome, all 3 can get involved, whereas the superior orbital fissure syndrome, also you get all 3 cranial nerve get involved. In the orbit, the 4th cranial nerve is most likely, followed by the 3rd, and very rarely the abducens can get involved due to 3rd nerve involvement. So these are the various sites where the ophthalmoplegia can happen. Some examples for painful ophthalmoplegia, where there is pain and ophthalmoplegia. Some of the causes that you have to remember. Number 1 is cavernous sinus thrombosis, superior orbital fissure syndrome, the Tolosa-Hunt syndrome, very common in diabetes, ophthalmoplegic migraine, orbital cellulitis and orbital tumors. So these are the causes where you could have painful ophthalmoplegia that you could see. The last component of the 3, 4, 6 cranial nerves is the nystagmus. So what do you mean by nystagmus? So nystagmus is nothing but there is a involuntary, please remember the definition, involuntary, conjugate, repetitive, rhythmic movements of the eyeball. So ICRR. So involuntary, conjugate, repetitive, rhythmic movements of the eyeball. So you will look at all 4 directions, not keeping more than 5 seconds, each direction 5 seconds, and see all the movements. So we have the grading of the nystagmus. So nystagmus can be only on deviation, that's grade 1. Nystagmus on primary position looking forwards is grade 2. And nystagmus direct opposite to the gaze is the type 3, what you could see. Various types of nystagmus could be there. The common ones, what we call it as the pendular nystagmus. So pendular nystagmus, so the amplitude is equal in all directions. So pendular nystagmus could be vertical nystagmus, it could be rotatory nystagmus. So in the vertical nystagmus, you could get very commonly, you would get it in cerebellar lesions, brainstem lesions. These are the common causes for the vertical nystagmus, whereas rotatory is commonly seen with labyrinthine as well as brainstem lesions. Now very importantly, please remember the vertical nystagmus is never seen with labyrinth. The vertical nystagmus is always either cerebellum or brainstem. Rarely it could be due to benzodiazepines or barbiturates. When they are there, you could get vertical nystagmus that you could see because of that. Gaze-evoked nystagmus is classically seen with your MLF lesions. So gaze-evoked nystagmus is the next type, which is seen with MLF lesions that you see. The other specific types of nystagmus, you have the seesaw nystagmus, which we see. That means one eye is moving up, the other eye is moving down. Classically seen with suprasellar tumors, which is present anterior to the third ventricle. So the craniopharyngioma is the classical example for seesaw nystagmus. Next you have the upbeat nystagmus, where it is going up, it is going like this. The lesions is at the vermis of the cerebellum, that's the common side. The downbeat nystagmus, the lesion is at the foramen magnum, the fast component is down. So any lesions at the foramen magnum, be it Arnall-Chiari malformations, etc. could be seen. You could have something called as an optokinetic nystagmus. One common example is what we call it as the railway track nystagmus, where both eyes are going like a railway track, parallel movements it's going. Classically seen with deep parietal lobe lesions. And then you have the classical nystagmus, which you see in the Parinod syndrome, what we call it as the convergence retraction nystagmus. So convergence retraction nystagmus is in Parinod syndrome. What happens here is the up gaze, when it is there is a palsy there. So there is a jerk nystagmus with the fast component with the inward component. So there is a convergence that is there, classically seen in superior collicular lesion, that is the Parinod syndrome. So there is an upgaze palsy. Whenever there is a convergence, there is a retraction of the eyeball also. Convergence nystagmus, otherwise called as the Collier's sign. So these are some examples of nystagmus that you have to know. So if you see here, very classically, this patient is having nystagmus, it's going up. So vertical nystagmus that is there on the up gaze, it is going predominantly up gaze nystagmus that you are seeing there. Even it is there in the rotatory, you can see there is a mild rotatory component also this is seen. So this is never in case of labyrinthine. This is the central nystagmus that you are seeing. Cerebellar disease, this patient is having classical cerebellar disease, where you have horizontal, up gaze, also rotatory nystagmus as well as vertical nystagmus. Classically seen with cerebellar disease that you can see. This is the second patient that you are seeing here, where you have the classical horizontal nystagmus with a fast beating to one side, bilaterally present here again, rotatory as well as torsional component is present. This patient is also having a cerebellar disease, not a labyrinthine disease.